Hi, I'm Dr. Duck Vuong, a world famous bariatric surgeon, author of 13 books. It's true, you can look me up. And I am
How
super
exciting.
excited to be interviewing a really good friend of mine, Dr. Michelle Gordon, who's a general surgeon living in Westchester, New York, just
I'm the
north.
world's #1 general surgeon.
There you just north of New York City. This is a serious matter, doctor.
It
You're
is.
really sick in the head if you're making light of the situation. So get
No,
serious right now.
talk about
Um,
COVID. Let's
I
talk about
know.
COVID.
She is normally a hormone specialist that helps millions, hundreds, thousands of ladies with their menopausal symptoms. But during this pandemic, she is taking care of some of the sickest patients in the New York City area. And it's an honor and privilege to have her with me today to tell us really behind the scenes what's really happening in New York. So round of applause for Dr. Gordon.
Thank
Yeah.
you. Thanks, everyone.
All
Appreciate it.
right, Doc. So give us, I think let's just jump right into it, man. What is the
Sure.
down and dirty? You
So
work in a
I
small
live,
community
yeah,
hospital.
it's a small community hospital. It's an hour, it's like a mile from my house, and it's an hour from New York City about. We have just under 200 beds. We have 20 critical care beds, but really we had 10. We had an ICU of 10. We had a PCU of 10. And because we don't have any ambulatory surgery, we have vents in our post anesthesia care unit as well. And so right now we have we're just at 30 ventilators in our hospital,
So what does
and
your hospital normally run? How many ventilators would be a normal
four to
every day?
five.
4 to 5.
Mm-hmm.
Wow.
Yeah.
Wow. Okay. So you're eight
Yeah.
times or so, 6 to 8
And
times
just
more.
just for anyone who's looking and sees how red I am, I mean, I literally 20 minutes ago got home, took off all my clothes, walked into my house in my underwear. I had I had my N95 on because
Mm.
it was doing procedures, and and plus a mask over that, and plus a hat, and plus shoe covers. So all my clothes, left them in the garage. Ran to take a shower really quick so I could get all of the virus off of me to come down and be ready. And then as
So
soon as I'm done with this, I have to go back.
so that's a good. So what's the routine now when you're going into the hospital?
I keep a mask I was keeping the mask in my car, and I decided to leave it in my box at the
Mm-hmm.
hospital. So the mask and the head covers in my box at the hospital, along with a pin.
Mm-hmm. And
So
are
if I
you
have to
wearing
write
normal
anything down.
scrubs or do you have?
Yeah, I'm just wearing scrubs. Yeah. So I've
Okay.
got like and then we bring them home and we wash them right away. And I wash my shoes too.
Okay. And um, are they allowing non-patients visiting visitors
No,
in anymore or
no,
no? Right?
no.
Yeah, because I've been saying that they're going to get to the point where there are no visitors allowed and people in
That's
the
been for
ICU are
two
going to
two weeks
die.
now.
So when
Two
these
weeks we've
patients,
had no visitors.
wow. So you can't go see mom or grandmother in the hospital.
No, and people are dying, and then we're putting the patients in the dead bodies in a refrigerated truck.
Wow. So the
Yeah,
reports of these refrigerated trucks outside of hospitals, that's really happening. That's a true
that's
thing.
real. That's
Okay.
real. Yeah,
And what is
that's real. I
that
mean,
like? Well, what is it
it's
like
there's
being a
just
surgeon and seeing that?
I mean the biggest issue is we can't really take care of our patients as well as we'd like. So I without giving away any privacy, um, we have one patient in the hospital who needs an operation,
Mm,
but had respiratory failure from COVID, and we
mm.
couldn't operate. And so if this patient recovers, we will be able to do the operation. But in normal circumstances, if he didn't have the respiratory failure, we would have been able to operate. But in this case, you know, we're not gonna be able to operate on her. So
It's a
uh,
travesty.
it's listen, the biggest issue is that and the people who haven't seen it happen yet, it's slowly making its way, right?
Hmm.
So remember, it's everywhere,
Hmm.
but it takes 14 to 15 days in places to before it manifests itself.
Yeah, I think
And
it's like a 5 day average, 5 to 7 day incubation
5.2,
period.
yeah,
Yeah.
average is 5.2 incubation period, which is a long time.
Hmm.
If you figure the common cold is 1.8 or so days, um, and so if it's not in your area yet, even if you're staying in, it's coming. It's
So
coming
what
for
are
everyone.
what are the presenting symptoms? Usually by the time the patients come to the hospital, What's the difference between getting admitted versus getting sent
Oh, it's
home?
respiratory failure. I mean,
So you
if
have to be
people
in
are
fluid respiratory failure before they
right,
will admit you.
but respiratory failure can be somebody who requires a non-rebreather and is not vented. Okay, so or somebody who requires a venti mask or supplemental oxygen. That's respiratory failure. In this case, what they're trying to do is send people home with concentrated oxygen and things like that. They're trying to keep people out of the hospital.
So the idea is if you feel like you have COVID and you have fever and shortness of breath, but you can stay oxygenated, they're going to send you home,
Yeah.
even
Yeah.
if you have signs of pneumonia.
If you have pneumonia, it's different, but I mean, it depends. It really depends. I mean, the problem isn't the pneumonia. The problem is the ARDS and the cytokine storm.
Mm-hmm.
Right. So what I mean by that, and if you watch Dr. Vuong's video that got about maybe more than 5 million views already on Facebook.
12 million.
Yeah. On YouTube.
Yeah.
Well, when I saw it, it was at 5. So,
yeah.
So when, if you saw that, what he's talking about, is the cytokine storm. And we just have so much inflammation that, our body just can't do it. And then, the alveoli get blocked up and then you have multi-system organ failure. So I've been putting in a lot of hemodialysis catheters, but none of those patients have survived. Not one. Not one. I mean, it's really rare to get off the vent. I've heard of one patient in the Bronx who got off the vent.
So walk us through this. So a typical, and I know it's hard for you to say what a typical patient is, but they're struggling to breathe. The ER doctor doesn't feel comfortable sending them home. So then what? You get admitted to a COVID floor or COVID ICU?
Oh, there's no COVID floor. It's COVID hospital. There's no floor. Everything is isolation. And as our hospital hasn't run out of PPE yet, but as we get, less and less PPE, we're not going to be able to change our gown every time we go into a patient room, right? Which is the standard of care. Crazy, yeah. So we're going to don once, and then everybody, we're going to go back and forth. I think that's what's going to be happening.
So then
especially
what
since
happens?
We have an ICU in the PACU now.
So what happens with like the patients who have like a heart attack or a stroke that are presenting with something that's non-COVID related? Are you guys shipping them off somewhere or?
That I don't know. I mean, I'm not an ER doctor, so I don't know what they're doing with those. I'm sure they're getting seen, but we don't have a cath lab. So at our hospital, not yet. We're in the process of building one. So they're probably getting shipped to a local cath hospital. But it's I mean, look, I've been doing medicine for a long time. You and I graduated our residencies the same time. And
you look so much younger than me. I don't know how that's possible.
I'm not younger than you. I'm probably about 10 years older than you, actually.
Oh, wow. Even better.
So, so I've been doing this a long time, and we've never seen a surge of patients like this ever. And it's just, and we're not even close to the peak. And so it's just, they're just continuing to come. I mean, if you look at even the logarithmic graph is going, it's not a straight line. I mean, it's going up.
No, it's bad. So I'm just trying to walk a patient who's concerned, maybe they have symptoms. If you're mild symptoms, if you're able to hold your oxygen saturations, they're going to send you home from the hospital. Maybe some supportive care, supplemental oxygen.
I think we can start sooner than that. I mean, let's look at what happens from an outpatient setting, right?
Okay.
What we would do here is you would contact your primary care doctor, who would then do a telehealth visit with you. And if they felt it was necessary, they would have you come in for a test, right? And right now it's a nasal swab, but next week we're going to have antibody tests. So let me take your blood. And then after that, if they find that you're having respiratory problems, they'll send you to the ER. They won't. A lot of people are going with fever and respiratory, symptoms, fever and shortness of breath, fever and shortness of breath, fever and shortness of breath. And then, it's a matter of chest x-ray and or CT. And, but I'm going to tell you, you and I, we've done our fair share of ARDS. I mean, when you do a surgical residency, you see ARDS because of trauma. So I've seen my fair share of bad x-rays, and I have never seen x-rays that look like this. I mean, this is bad. And it is, the lungs just, they just look like shit. I don't have any better way of putting it. I mean, it's the shittiest x-rays I've ever seen in my career.
So just a lot of opacities everywhere, like spots everywhere.
Yes, and ground glass, a lot of ground glass.
Yeah.
Yeah.
And there's some reports talking about how somehow this coronavirus ARDS is different than regular ARDS. There might be an inflammatory response with a lot of thick mucus production and clogging the bronchial airways. What's been your experience with
Yeah,
that?
that's what's, I mean, I'm not doing any autopsies, but that's what came out of Wuhan is that, you know, especially in some of the early studies with people who had, you know, wedge resections.
Mm-hmm.
So they're like portion of the lung was removed, and then they found these thick mucus secretions, and they found COVID in these lungs. But the problem is the inflammatory response with all the white cells coming in, and then there's this, you know, a lot of pus. But with, you know, look, for me to go back to remembering all of the inflammation markers, and, you know, I mean, I'm a technician at the end of the day, right? I'm a general surgeon, and what we do is we fix things. And so, you know, it's been interesting for me to go back and rediscover a lot of immunology and physiology because of this.
Yeah, me too. I had to
You
look
got to
up
go
a
back and
lot
look
of
at the
stuff.
textbooks, right? Because because we don't have to deal with it. I mean, a general surgeon will see, for the most part, the most inflammation we'll see is like a trauma patient
It's probably
that
trauma with
yeah,
sepsis. Yeah.
yeah,
Yeah.
yeah. And so this is worse than that.
Wow.
And once they get on a vent, they most of them don't survive, and
So
they
what are
go
you
into,
seeing
you know, renal
progression
failure.
time-wise in terms of like from if they're having trouble breathing and they're not ventilated yet, how quickly is this progressing? Because the news is really trying to scare people about how
It's
quickly this,
fast. It's
like,
fast. 4 days,
really,
5 days. Yeah.
wow. And
I
then,
mean, but some people get better. Listen, some people get better. Remember, you know, 5% of the people who get COVID, it's 5%
mhm,
are serious. Okay. 5% are seriously ill. So 95% of the people are going to have some runny nose, some chest discomfort, maybe some difficulty breathing, but not, you know, like walking upstairs feels hard or something like that. Some people may lose their sense of smell, lose their sense of taste for a short amount of time. We're seeing those symptoms. When I think I had my cousin, I was with my cousin at the beginning of last month, and she, you know, came back positive, and didn't, you know, I didn't know until like many days later. I'd already been home for like 12 or 13 days by the time she knew. And when I came home, I like had a scratchy throat, I had a runny nose, I had a little cough, but it wasn't bad. I was still able to exercise, you know, that sort of thing. So, so this isn't, I mean, most cases are mild, so we can start with that. But of the severe cases, they're really bad. They're
so
really
what do
bad. And
you,
of the recovered cases, 21% of those are deaths.
yeah, so as the on-call surgeon, what are you being asked to do to care for these patients right now?
You know, it's just lines. It's just vascular access. So that's
So they
pretty much
need
it.
central lines. These are big IVs that are you
Yeah.
putting them in the
I put
subclavian
them in.
area?
I usually go IJ. I use ultrasound and
Okay,
go IJ.
so, right, so
I'm
you
most
can go to,
comfortable there.
and this is you guys, for those of you watching, you've probably seen where someone in the hospital has like these big IVs coming out of their neck or their shoulder areas, and you use those to give some of those heavy, powerful medicines, right?
Yeah.
Are you seeing a difference? Is your hospital starting to use the hydroxychloroquine and the
Oh yeah,
Z-Pak
they
and
use
all
it.
that
Doesn't
stuff?
work. It doesn't work. It looks like it's really working in the outpatient setting more than anything else. And so, you know, there is an anecdotal study, not study, it's an anecdotal report out of Curious Joel, which is in Monroe, New York, which is about an hour from me, and that's a big Hasidic community.
Hmm.
And the doctor who takes care of them, as soon as they start showing symptoms, will give them Plaquenil and Zithromax, and they haven't had any hospitalizations, or so they say. It's hard to say. It's completely anecdotal. There is no study behind it.
I think that's important that people watch and understand that because there's a lot of, unfortunately, I've started listening to the daily updates by the presidential team, and I
I
just
can't do it.
don't
Can't do
do
it.
it. Don't
Yeah.
don't do it. It's
Yeah.
every
I
time he
can barely listen to
starts.
Cuomo. I don't listen to Cuomo either.
Every time he starts talking about medicine terms, I'm like, oh my God, you are so misleading the general public because he's talking about like, oh yeah, you should just try it. Just like, what could it hurt? I'm like, oh my God, you
Well,
can't do
the
that with
issue with
Plaquenil
Plaquenil is we're seeing a lot of,
QT.
yeah, according to my ID colleagues, we're seeing a lot of side effects, and it's not worth
Mm.
it. So, but I don't know what those side effects are. So I'm not, this is just anecdotal. But one of the things that, because for those of us who are on the front lines, and if you're a nurse or a PA or a doctor or a nurse practitioner or a nurse anesthetist or somebody who is in there seeing the patients, the recommendation is supplement with vitamin C and zinc.
Right.
So, but don't take too much zinc, guys. You can overdose on zinc. So just take 220 milligrams. That's it. And only for 2 weeks with zinc.
So when the initial reports were coming out about the whole Plaquenil and azithromycin, I was thinking back about, their mechanisms of action, and it just occurred to me, it was like, why would this help if if the virus is already in your lungs in the ICU? I mean, this would only work if you took it either preventatively or very early.
Right. Well, I don't
like you said, the outpatient setting.
Yeah, the outpatient setting, apparently it's working. I don't actually know the mechanism of action of either of those drugs, and I haven't looked it up. So if you want to let me know, then we can talk about it. But at the end of the day, what we're trying to do is treat overwhelming sepsis. And so, we have the cytokine storm, we have pneumonia because of that, and then we get multi-system organ failure after that from the sepsis. And
and as a weight loss surgeon, my following is mostly obese patients or formerly obese patients, and a recent study or report looked at intubated ICU patients, and something like 70 to 80% of them were obese, and not super heavy, and like 50, 60, 100, BMIs of 35 sort of. Are you seeing that in your hospital?
In our hospital, it's, a lot of older people. I mean, we got an older population. We got lots of nursing homes in the area. But I did put, yesterday I put a line in somebody who was probably a BMI of 60. And today I put a line in somebody who's probably BMI of like 40, 45. So, it's a confounding factor. Sure. I mean, obesity is a confounding factor for lots of diseases, cancer and whatever. I don't have to tell you that.
You're right.
So.
And then you messaged me today and said you put in dialysis catheters. What's happening there? Can you explain what's going on?
So it's multi-system organ failure. So we're having sepsis, and because of my renal colleagues are saying is because of the cytokine storm, it's affecting all the organs. We're seeing cardiac damage from this. We're seeing renal damage from this, and we haven't. I mean, all the patients I put dialysis catheters in last week died.
Wow.
So,
wow.
Yeah. It's really, this is a virus that is to be respected. I mean, right now it has a 4.6% mortality rate overall, and time is going to tell. Time is going to tell, and at the end of this, when we are able to reform our medical system and burn down the middle managers who have taken all, we need, I mean, I don't know if anyone saw the Z-Dog manifesto. It's an 8-minute thing. Yeah, it's really, really good. I like Z-Dog a lot. But, at the end of the day, we've got a broken system in America, and it's showing. And there is an expectation that doctors are going to just volunteer their time for this.
Yeah, I saw your post about that, and I absolutely agree with you. They take advantage of our altruistic nature, and unfortunately, we have to give it during these time periods, but it's during
No, we don't. No, we don't. No, we don't. There are no emergencies in a pandemic. We don't have to give it.
Okay.
I'm sorry. I mean, if there's no PPE, I'm not going to the hospital. I won't. And if that means I have to resign my privileges, that's fine. But at the end of the day, why should my family lose their mother, their wife, because of, a hospital system?
You bring up actually a really good point, because that is the concern for a lot of other healthcare providers, nurses, our phlebotomists, do you feel like we'll get to a situation where nurses won't come to work and techs won't come to work? And
if there's no PPE, that is certainly a possibility. Our nurses are unionized. And so, in the ER, it's goggles and hats and gowns and double masks. That's what I'm seeing in the ER. At the end of the day, the problem is that we're taught, and we have, doctors have a calling. We really do have a calling to serve other people. And it really is, it's part of our soul. I mean, it's a sacred calling to help. And what happens is that we value other lives over ours.
Mm-hmm.
And I think in a crisis like this, I don't know if that's warranted.
Hmm.
I don't know if that's warranted.
Well, I know for sure that there's been a huge outpouring of love, like I've never seen, for
Yeah.
our healthcare workers from the community, and everybody in the front line, like yourself, absolutely deserving of it for sure. But like you said, we're not even on the apex yet. I mean, New York is peaking up. How much worse is it going to get, do you think? Like, what are you guys going to do?
I think, as long as we can get ventilators, we'll put ventilators everywhere. I mean, I'm going to start seeing medical patients. My wife is a internist, and she's overwhelmed with patients. And I said, look, I'll see some of your patients with you. You just help me, figure out the plan, and I'll just
Hmm.
start seeing the patients.
So, they talk about Italy, like not intubating people over 80 years old with COVID disease. There's talk about not resuscitating patients who code if they're already on the ventilator from COVID. Where are
We're
you
not,
guys at?
yeah. I mean, we're currently, I mean, we're coding people, I think, but it's,
But they don't really survive, do they, if they code?
no.
Yeah.
No. So we, if you remember back from residency, and anybody who's a medical person will know this, it's called a slow code, and all the ICU guys will say that there is no such thing as a slow code. You don't slow code, you either code or you don't. In something like this, it's basically you push some drugs, you plus minus compressions, and
Hmm.
that's it.
Hmm. So I get a lot of questions about DNRs, and there's people talking about that now. That's a do not
Yeah,
resuscitate order. Is that
yeah.
something? How would that affect your management if someone had a DNR? Do you recommend people getting DNRs? Like, where do you stand on that?
Well, I think it depends. I mean, if you have a 50-year-old who somebody TMT, can you mute your microphone? Or somebody needs to mute. So if you have a young person, um, it really depends on how people feel about death, right? I mean, at the end of the day, there's a 100% mortality rate across the board, right?
None of us are getting out alive, you mean?
Right, exactly. And so, and we as a medical profession are vilified for mortality and morbidity and these sorts of things, right? But in this particular thing with a disease that we can't treat, if you may want to do some advanced directives and decide that you don't want people pushing on your chest and breaking your ribs, and
Hmm.
you may want some ventilatory support, because at the end of the day, there's a small possibility you could get off. I don't know what the stats are, but I don't know if it's more than 5% of the people who are vented are actually getting
Hmm.
off. Some people do, but not
So,
that many.
I know it's probably pretty hard for you right now since you're really in the middle of all of this, and
Mm-hmm.
like you said, you're going back to the hospital after we're done here. Um, what would you say is a major lesson you've learned from this?
I, I'm angry. I think I was angry before as a healthcare professional in America, and I'm more angry now. I'm angry that doctors are expected to volunteer their time while nurses are paid $15,000 a week. Respiratory therapists are paid $10,000 a week, and doctors are expected to volunteer their time. I'm angry about that. I'm angry about the fact that doctors are not viewed as valuable enough when we are really the backbone of the healthcare system in
Mm.
America.
Well,
Um,
why do you think that is?
I think it's the because back in the 70s, insurance companies became private instead of nonprofit. And then we had the whole Stark debacle in the 80s, where normal business practices that were performed by doctors were found to be um, unethical
Illegal.
by our colleagues in Congress who practice exactly the same thing. So a
Yeah, it's a
huge
double
double
standard for
standard,
sure. Yeah, absolutely.
huge double standard, huge
Hmm.
barriers to business. And then we had the corporate, the corporatication or whatever, corporatized. Medicine became corporations, and we became commodities. And as we became commodities, we became expendable bags of meat.
But
And
but nurses are commodities. Why are they getting paid, but we're
it's
not?
I because we can bill for our services, but most of us are not. Most of us are not. I mean, many doctors are employed now, and there's a whole thing in medicine that doctors are not taught business, so that they can they have to come in and be dependent and be employees. The whole compensation model is screwed up.
Mhm.
Being an employee for a big corporation, as a cog in the wheel. I feel for the nurses, but the nurses at least have figured out a way to organize and have a voice.
Well, it's actually against the law for us to for doctors to unionize.
Well, not 100%, because my friend's husband is an anesthesiologist and is part of a union in New York City. So it's
Hmm.
not 100%, but it is, that's part of the Stark thing, was that we were not able to, I mean, we were completely handcuffed on the business side, and then on the professional side of our billing practices and how we perform business. And now with the whole surprise billing problem, that whole surprise billing thing
What's that?
has
What's the surprise
um,
billing?
so the state, not the state, the federal government is trying to change the way that, and it's really the insurance companies that are doing this. If you don't have a contract with an insurance company, it used to be that you could just bill your services and they would pay it.
Hmm.
That's how especially in the case of an emergency. And what has happened is that the insurance companies have decided that that's too big of a loss, and so they've gone to creating laws. And now New York has an arbitration system where it has to be based on, it's like a baseball arbitration, so it's based on like the 80th percentile of what everybody bills,
Hmm.
which is more fair. So we have something called fair health here in New York, but the national law basically just lets insurance companies set the out-of-network rates.
Hmm.
That's price fixing. And it's okay for them to do it, but it's not okay for anywhere else to do it. So there's a lot of issues. It's a real challenge to have a bit, business. I mean, as a matter of fact, I'm not going to be in business much longer because I'm closing my practice, and I'm closing it. It was a lot more people. I had 5 surgeons, and I'm going down to just me, because it's impossible to run.
It really is, and I just don't think the American or the average person understands how hard it is to be in business as a doctor.
No.
It's
Well,
really
oh,
really
let me just. So anybody here who has a business, right? So I don't know, if you have a business, just put a 1 or a yes in the chat. And what happens in business is you have a contract or an agreement with somebody, right? And then you get paid. So you say, you're going to pay me a retainer, and then I'm going to do half the work, and you're going to pay me a little bit more, and then at the end of the work, you're going to do it. In medicine, we see a patient, and then we fight with an insurance company to get money, and I'm still getting paid from 2015.
Yeah, the way I like to explain it is this. In medicine, we do the surgery first, and then they'll pay us months later, and then they might only pay us a fraction of what they agreed to pay us.
Right.
So this is the equivalent if you went to a restaurant, ordered a $200 dinner and really had a good time, and then said, "Hey, I'm going to pay you in 3 months now after you've eaten your meal." And then 3 months passed by and said, "It was a great dinner, but we've decided that it's only worth $100 and not $200. And then here's your
Right.
$100. Take it or leave it. If you don't like it, take me to court."
Yep, and that's exactly it. That's a
Hmm.
really, really great analogy. And for somebody like me, I mean, I pretty much only do acute care general surgery, and so I'm saving lives. And then they decide that the life that I'm saving is only worth
Pennies on
$500.
the dollars. Yeah, penny out. Yeah, of course.
Yeah, yeah.
So what would you say to people who still think that this is way overblown? It's all media hype. It's to get Trump unelected, or what would you say?
This is real. I mean, New York is the epicenter for America. And I'm not even in the city. And a lot of residents, residents are dying. Those are doctors in training who are dying. Doctors aren't going into, attendings aren't going into COVID rooms in some of the training hospitals. Only residents are going in, they're writing notes. Doctors are still billing. They're not seeing patients. So it's the issue here is, lack of proper personal protective equipment. And then, there's a lot of fear. There's a lot of fear because people are dying. And, if you're in my age group, I mean, I'm 55 years old, and I'm in a higher risk group, so if I get it, I mean, I think I might've already had it, but I didn't test myself. I'll get an antibody test when that's ready. But, and then on top of that, I mean, this with when you look at Trump's tweets,
I try not
the
to.
Chinese, the Chinese virus is under control. It's not going to affect us, and you just look at the history of his tweets and then him, saying we're going to open up the country by April 12th, which is Easter. And, by April 12th, we ought to have, I mean, it looks like it's going to be close to 1 million cases, if not more.
Yeah.
And we're going to be more widely testing. So we've done about 1.6 million tests. And of those 1.6 or 1.7 million tests, we've got, 320,000 are positive or so.
Mm-hmm.
So the virus is to be respected, even if there's not that many. It always starts with one.
Well,
and that's the thing.
What about these knuckleheads who still think it's an old person's disease? What would you tell them from someone who's on the front lines fighting this?
No. Young people are dying from this.
Like dying,
Young
not
people.
getting sick, but they're actually dying.
Young people are dying and they're getting vented and dying. I mean, I put lines in 2 people who are in their 50s today.
Hmm.
And there's younger people than that. I mean, there's reports of, there was a child who died somewhere in the world. I can't remember where. There's people in their 20s and 30s who are dying.
Yeah, I just don't think the average person understands that even if 95% are going to survive this, 5% of a huge number is a huge number, and it's going to be a massive amount of loss. And, I'm an Asian immigrant, so I'm one of the Vietnamese boat people. And so I love America and I love the heartland of America.
You come over in the 80s?
78, yeah.
Okay.
And so I love the heartland of America, but they're not as hard hit. So what would you say to some people who are like in Nebraska, Kansas, Iowa, Wyoming, where there's not that many cases and they just don't know what the big hoopla is all about?
Well, stay home because it's coming for you. I mean, there were a bunch of kids who were at spring break and they tracked their phones and could see how they took COVID with them.
Yeah, they took it from Miami, from Florida, back home.
Yeah. Mm-hmm. Yeah. So, I mean, the only way it's going to work is if people actually follow the quarantine, rules. I mean, that's the only way. I mean, we have to stay home. I mean, it's exactly what happened in the bubonic plague. It's exactly what happened in the Spanish flu epidemic. And then one of my colleagues from medical school pointed out that 500 million people died of smallpox. I don't know what the time frame is on that, but smallpox was really, really bad. And it was finally eradicated, off the face of the earth because of vaccine. But that wasn't a coronavirus. Like, the coronaviruses are a really interesting group of viruses. I mean, that's the common cold. And we don't get immunity to it. We get it, and then we get better, and then we get sick again.
And there are like animal versions of it too, like our pets, like feline versions and stuff like that.
Cats and dogs get it too. Yeah.
It's pretty crazy.
But yeah, all I can say is that the virus should be respected. And this is, from infectious disease colleagues. And if there's no PPE there, nobody's going to get any care because it's, there's no emergencies in a pandemic. And in Ebola, when they were doing Ebola, they somebody was coding and dying. They were still taking 10 minutes to suit up. And we're not able to we don't have the proper stuff. I mean, it's what we really need is hazmat suits, and we don't get that. we're doing the best we can with what we have.
Yeah, there's been a list. I don't know if you've seen it, but there's been this list that Medscape, I think, has started from all of the doctors, just doctors, not nurses. CHMJU, could you mute your phone, please? I got it. So yeah, there's this list where they're listing only the names of doctors who died from COVID,
Yeah.
and it's pretty long.
Yeah, people are dying. And we're it's viral load, right? So we've heard about viral load back from, HIV. We had an HIV crisis here in the 80s. And it was bad and people didn't want to go into the rooms, and it was, similar. It was a pandemic. And if, we talk a lot about viral load when it comes to HIV, and we've been able to, maintain HIV, right? We've gotten drugs that manage it.
No vaccine for HIV.
No vaccine for HIV, just treatment.
And everybody's hanging their hats on this whole coronavirus vaccine. And like, if we're lucky, we're 15, 16, 18 months away.
It's a different thing. Remember, HIV is highly mutable on the surface, which makes it really, really hard to do a vaccine. Coronavirus, according to what I've read, is not as mutable. It's mutating, but there are certain things that are staying the same about it. And so they may actually be able to do a vaccine. But, so HIV is now a chronic disease. Great. But we still look at viral loads. And that's something that we look at. And so when you're exposed to it every single day, you're going to have more and more viral load. That's why doctors are dying.
So back to what you were saying about, when are we going to get over this? And I used to say we were going to peak in the middle of May, but probably more accurate would be there are going to be different peaking times for different cities. Would you agree with that? Like, it seems like hopefully New York City is going to peak soon. I think Seattle's already peaked, and we're going to see a wave of cities peaking.
Yeah, I mean that's makes sense that it'll be, Seattle should have peaked already. I think, I don't know if Italy's on the downtrend yet. I haven't looked at Italy for a while.
Yeah, they've done good in Italy. Italy's slowing.
Yeah. We're still going up, and we'll be going up. Remember, when we get to the peak, it's going to be 2,500 deaths a day, and then we're going to have 2,499, and so lots of people are going to die. But I think we're going to see, waves across the country. And I think we'll, if international travel is not going to happen probably for 18 months, if that, and travel within the country is going to be dependent on, whether or not you're coming from a peak place or not. We're going to have to stay where we are for at least until the end of the year.
Containment's going to be super, super important. So how does somebody protect themselves during this time period? What's the best way, would you say?
Stay home, wear a mask when you go to the grocery store, only buy what you need, wear gloves at the grocery store, and don't touch your face. And then as soon as you get home, everything comes off and goes right into the wash. Right into the wash. And wash your hands first. As soon as you take all your clothes off, wash your hands, and then right into the wash.
And I guess that's really super important if somebody is in the healthcare field or is an essential worker, driver, whatever, grocery store clerk, and they're living at home with somebody who's at high risk. Wouldn't you say they need to be super cautious?
Yeah, I mean, my son is one of these. My son is a survivor of childhood cancer, and he has asthma and a bunch of other medical conditions because of it. And so we went and got him. He lives in an assisted living facility in Cape Cod. And when I saw that this was going to be pretty serious, I thought, I don't want him getting sick in Massachusetts. So we went and got him and brought him home, and he's been home for a month.
You don't worry putting him at risk there at home with you?
Well, we're taking precautions, I mean, like I said, everything stays in bags and then gets washed right away. If he gets sick, I want him near me. I don't, I want to be able to manage his care.
Yeah, I feel the same way about my kids.
Yeah. So let's see. Janelle asked, is there more than the viral load that puts you at higher risk? Yeah, there's a lot that other than viral load that puts you at higher. It puts me at higher risk or puts other people at higher risks. That's the question. I mean, advanced age, um, comorbid conditions, especially hypertension, heart disease, and any lung disease.
Yeah, so definitely there's like the viral factor, there's the virus, and then there's the host. So
Yeah.
depends on host factors too, how young, how healthy, comorbidities, as you say. So,
And then Elise is asking if there's reinfection. I am not aware of reinfection, but I am going to say that since we do get reinfected with the common cold, I think that that is going to be the big bugaboo with this particular disease.
yeah, but the difference is like hopefully you build immunity, and so every time you get exposed to it, you have antibodies that fight it, so it's less and less severe. And I just don't think we know what's going to happen with this coronavirus. Having said that, we do expect a second wave, don't we, to start in October when the season gets colder again?
Yeah, I mean, again, I'm not an epidemiologist, and so I don't know. I mean, I think we're going to see waves and waves and waves for like the next 5 or 6 years, and I don't think we're ever going back to, what was normal before.
Hmm.
And thankfully, we've got technology so that it's physical distancing, not necessarily social distancing. Like we've got 100 people here on this call.
Let me do,
It would have been
let
a
me,
lot more if we'd been able to go on Facebook
I know
Live.
we would have had thousands. We're going to do it again. Uh, Let me do some quick kind of question and answer with you real quick.
Yeah.
One you've already answered. Can you catch it again if you caught it once?
I think so. I don't know, but I think
Okay.
so.
Ibuprofen, good or bad?
Bad.
So they shouldn't be taking ibuprofen?
No, ibuprofen, we don't give it to patients with asthma. And so if you've got ibuprofen in your system, and I don't remember the mechanism of action and why it is, remember, I'm a surgeon, I'm not a medical doctor. So, we're truly technicians. Our job is to fix things. And so, when it comes to that, I just know that I don't provide I don't give Lovenox, and I don't give, ibuprofen to patients with asthma. So with lung disease.
Yeah, I think it's a
So
prostaglandin E2.
prostaglandin inhibitor. Yeah, there's something with the prostaglandins. Yeah. So,
Okay.
and just remember, with the cytokine storm, it just makes everything worse. So we want to make sure that ibuprofen, Aleve. Those guys are not good. Tylenol's okay.
Do you think this was made in a lab?
No, actually, the genetics prove that it wasn't. And of course, that's the Wuhan virology clinic is or lab is right there next to the wet market. But no, it really does look like it's a novel virus that jumped from a bat or a pangolin.
Right. Do you think this is a biochemical warfare?
No, I think it's a novel virus that jumped from an animal to humans, and we have no immunity to it.
Okay. Does wearing homemade masks and scarves help or not really?
If you cover your hair, it'll help. As long as you wash everything as soon as you get home. Um, and it depends. If you make your mask out of a HEPA filter, then yeah.
Is the virus airborne?
It can get aerosolized, right? So remember, we sneeze. It's it can be 10, 12 feet when we sneeze. According to China, it's not airborne. It's not.
Do you believe the data out of China?
No, I don't believe anything out of China or Russia or any communist country.
That's
And I think
always
I don't think that China's numbers are accurate. I think that they probably have, as many or more. I mean, they've got the most people in the world, and so they've got as many or more than the U.S., and they're just not reporting.
yeah, exactly. So 1.5 billion country, Wuhan itself is 10 to 20 million people. How can they
And
only
it's a
have
major
83?
hub. It's a major
Yeah.
hub. No, it's just, no. Now they've got probably 3 or 4 million people that are positive.
Wow.
And the studies, the reports are that there are lots of urns. There's lots of urns from cremated bodies that are just getting dropped off, and so the numbers coming out of China are not accurate. The
So
numbers coming out of Russia are not accurate.
so just to summarize, this is a bad player. We got to respect coronavirus. And just to
Yeah.
clarify for everyone watching, there are no visitors allowed in the hospital, right?
Right. No visitors in the hospital. And don't go there. Why would you want to go there? I mean, I've always told people, why are you hanging out in a hospital? That's where the germs are. And, go to the hospital, say hi to your, family, and then get the hell out of there. And
Right.
and now you
So
can't even do that.
So patients are going to die alone, yes?
Everybody dies alone.
Yes. And there are
I mean, that's just the truth. Nobody,
yes.
nobody dies with somebody, so everybody dies alone.
And it's true that there are refrigerated trucks outside the hospitals for all
That
the
is
dead bodies.
absolutely true. We have to do
Okay.
something with them.
Now, what's going to happen to those dead bodies? Do they get cremated? Does the virus
Well,
live on the dead bodies?
I don't know. I mean, probably it's still, until there's probably still virus there, and I don't know what they're doing. The funeral homes are having a booming business right now. But I don't know what they're doing with the bodies. I mean, China's cremating them, and that's probably the best way because that'll kill it. There's no funerals right now.
Yeah, you can't have gatherings.
You can't have gatherings, so um, and I don't know if there's any coronavirus vaccines. I don't know of any particular vaccines for specific coronaviruses. But again, I'm not an infectious disease doctor. I'm not a biologist anymore. I'm just a surgeon.
Just a poor lonely surgeon.
Just a poor
You're
lonely
doing great,
surgeon.
amazing,
Yeah.
amazing work. Amazing
Um,
work.
and
Any last
Teresa
go
Teresa
ahead.
asked what I'm doing to protect me and my family, and I did say it before.
Mhm.
So when you watch the replay, you'll hear it. But basically, what we're doing is scrubs only in the hospital, all clothes off as soon as we get home, wiping down our car with bleach when we get back, and then immediate shower. So we walk in with our underwear or a robe, and then it's an immediate shower as soon as we get home.
Yeah,
It's going to get really bad in Albany. And actually, they're shipping patients up there now.
that's crazy. And just so you know, I've been trying to share this onto Facebook Live and even YouTube, and it won't connect. So
Yeah,
I'll
that's
just
okay.
edit this video down, and we'll do it again. I hope you'll come back. And
I'd love to. And tomorrow morning, we're on for 8 a.m. on my page,
yeah, let's talk about that.
Dr. Michelle's
I
Burton
don't know
page.
what I could add other than some
Oh, it'll be good.
comic relief, maybe.
No,
But
it'll be
I
good.
just wanted to honor you, Dr. Gordon, for all the hard work you're doing and putting
Thank you.
yourself at risk. And I think that the people who watch this and who will watch this later will definitely agree with me. It's a scary times, and
Yeah.
you're really heroic and courageous for stepping up to the plate and going back, because you're going to go back after this interview into the
Yeah. I
hospital.
have to go back and put in another line.
Yeah,
Vascular access.
and not only are you putting yourself at risk, but you're putting your family at risk. And so
Yeah.
I want to honor you. And I know you said
Thank
you
you.
want to, this is going to be a hard time to practice medicine. So how can we help support you? How can we follow you? I know you're really active in the hormone space and the
Yeah.
menopausal space. Is there anything
Yeah, so
for the people
if you're a
watching?
woman who is looking to end the misery of menopause, we call that mental misery in our world. And if you're looking to end the mental misery and kind of get your life back and become what we call a menomate, just go to learn.menopausemovement.com/start, and we've got a free training there for you all about getting out of mental misery.
That's crazy. You're like sitting here giving away a free gift, huh? Free training. Do that
Yeah,
website one more time.
learn.menopausemovement.com/start.
And I'll be sure to put that on the video and in the
Thank
links.
you.
So, and I
Thank you.
hope
I
you guys will
appreciate
share
it.
it. And when I put this
Yeah.
video up, I hope you guys will share it. It's super important. Dr. Gordon,
Yeah.
you've been awesome. I mean, you're
Thank you.
amazing. You're a hero in
Thank you
my
so much,
eyes. All right.
Dr.
Love you
V.
very much.
It's been great hanging out with you. All right. Bye everyone. Thank you.
Thanks,
Thank
everybody.
you
Bye
so much.
bye.